Morning, everyone. This presentation examines the cost of removing financial barriers to treatment, uptake and adherence as effective public health strategies for improving health and reducing HIV transmission in Australia. It will identify factors contributing to financial stress in people with HIV, such as high rates of comorbidity and health-related costs, reduced rates of employment and income, and the association between financial stress and deferring or stopping treatment. It will examine the lifetime cost of each new HIV infection and estimate the cost of waiving antiretroviral co-payments for the population with diagnosed HIV and undiagnosed HIV in New South Wales. And finally, it will look at how this work is influencing advocacy in other Australian states and territories. The Australian 7th National HIV Strategy includes targets to reduce sexual transmission of HIV by 50% and to increase treatment targets to 90%. And the New South Wales HIV Strategy, which came before that, embraced more ambitious targets. In Australia, the Pharmaceutical Benefits Scheme lists all medicines available to patients at a government subsidised price, and the price paid by patients is called the co-payment. Working people pay the full co-payment amount of $36.90 for each medication, and if they are unemployed or receiving a government pension, this amount is reduced to $6. HIV medicines are all listed on the PBS list. Financial stress and the cost of the co-payment for HIV and other medicines are significant barriers to the initiation of ART and adherence. Research conducted by John McAllister in 2012 found that financial stress is directly associated with reduced treatment initiation and adherence in Sydney patients. People with HIV also experience much higher rates of comorbidity. People with HIV also experience higher rates of comorbidity, and the management of multiple chronic health conditions is associated with higher out-of-pocket health spending. As people struggle to balance the financial burden of health-related costs with other living expenses, decisions about ART initiation and adherence are negatively impacted. In 2013, 357 people in New South Wales were diagnosed with HIV. The lifetime cost of each new HIV infection in Australia is estimated to be about $483,000 to $570,000. The Australian Government provides notes to Commonwealth medical officers on the cost of health-associated care, and for people with HIV on first or second line therapy, the average cost per year is between about $13,800 and $16,300 each year, and for those on third line therapy, it's about $19,000 a year. So the accumulated lifetime cost of each of the 357 HIV infections in New South Wales alone in 2013 would be $172 to $203 million. And the projected cost of the 1,253 Australian HIV infections in 2012 would be $605 to $714 million over that lifetime. To persuade government that reducing the cost burden of antiretroviral medications makes good public health and economic sense, Positive Life New South Wales developed costings for a waiver of ART co-payments for people with HIV in that state. New South Wales is the Australian state with the greatest number of people with HIV. In 2014, New South Wales had an estimated 10,500 of the approximately 24,000 people in Australia. Victoria with about 5,600 and Queensland with about 4,300 were the next largest states, followed by Western Australia, South Australia, the Australian Capital Territory, Tasmania and the Northern Territory. The number of people with HIV paying the full co-payment or a concession was estimated using self-reported employment data from the Sydney Gay Community Periodic Survey. The data, the chart on the left, identifies the proportion of HIV-positive respondents to the survey who were working full-time, 59.6%, working part-time, 18.8%, or receiving a government social security payment and eligible for a concession healthcare card. And of course, these rates are much lower than people without HIV. The average number of HIV medications dispensed per person was established with assistance from two major hospital pharmacies. The Albion Centre reviewed the HIV dispensing patterns of 1,573 patients in 2012, and the results are in the chart on the right. They found that 24% were dispensed one individual item, a three-drug fixed dose combination pill. 47% were dispensed two items, 22% were dispensed three items, and 7% were dispensed more than three items. St Vincent's Hospital Pharmacy, which is another dispensing place in Sydney which does large numbers of dispensing for people with HIV, found similar results. So for the purposes of the calculation, we used 3 antiretroviral items per person for the costings. This slide shows patient costs over a 12-month period in 2014 for a combination of 1 to 4 antiretroviral medications and 1 to 5 other medications, bearing in mind that people with HIV often are taking many other drugs as well as their antiretrovirals. The top table is where the full co-payment is charged, 3 antiretrovirals in red. So the annual cost of 3 antiretroviral items and 2 other medications would be $1,547 a year, and the safety net cuts in at $1,421, so you can see that there's very little benefit till very late in the year for most people. The cost for people on a concession is in the table below. In New South Wales, patients are dispensed 2 months' supply of antiretroviral medications per payment and 1 month's supply of other medications, so the cost of antiretrovirals is effectively halved in comparison to other medications. The table in this slide estimates the yearly cost of waiving ARV co-payments for the 10,500 people with diagnosed HIV in New South Wales in 2014, where they're prescribed an average of 3 items and either pay the full co-payment amount, so they're employed full-time or part-time, or eligible for a concession co-payment. The estimates include calculations for different population treatment uptake levels from about 70 to 100%. The 90% is shown in red. So the cost of waiving antiretroviral co-payments and providing free treatment to all people with diagnosed HIV in New South Wales in 2014 would be approximately $5.1 million a year, 90% on treatment. If a waiver were available to those on low incomes, so those who are working part-time and eligible for a healthcare card, probably in the vicinity of under $40,000 a year, the cost would be $1.8 million a year, and for those on a concession, it would be about $221,000. The yearly cost of treating the 15 to 20% of people who are predicted to be infected with HIV and yet to be diagnosed and treated would be about $770,000 a year, to about $1 million, perhaps $1 million, 90% treatment uptake. So for less than $6 million a year, all people, both diagnosed and undiagnosed in New South Wales, could be treated with a 90% treatment uptake level. If 80% treatment uptake was obtained, it would cost about $5.2 million a year. So how has this work influenced the advocacy in New South Wales and other Australian states and territories? In New South Wales, there will be no blanket ART co-payment waiver at this time. There are concerns about setting precedents and potential flow-on claims for other chronic disease groups, mental health, cardiac patients and organ transplants, etc. However, local health districts have the discretionary power to waive co-payments for individuals on a case-by-case basis. And a policy is currently being developed where PLHIV who need support can apply for a co-payment waiver. In Victoria, a detailed analysis of the cost of ART was conducted by the Burnet Institute. The findings highlighted the need for a more equitable approach to ART distribution in Victoria and to reducing financial barriers for people with HIV in that state, and not just for those who can access ART from a single Melbourne site that provides free access. Queensland Positive People have been working in close collaboration with NAPWA and with the HIV Foundation to strongly encourage the removal of ART co-payments by the Queensland Health Department. While the proposal has been viewed favourably, it is yet to be approved for implementation. Positive Life South Australia are developing a state-based submission based on the work in New South Wales, and that is hopefully going to go to the government very soon. In Western Australia and the Northern Territory, co-payment charges are waived or supported through the state and territory respective health systems. And in Tasmania and the Australian Capital Territory, our populations are small and we don't have good data at this time. So in conclusion, efforts to reduce the cost burden of antiretroviral medications in Australian states and territories have been mixed. States and territories are diverse in terms of PLHIV population size and demographics, and there is a mix of approaches ranging from some public health sites and even jurisdictions providing free access, others promoting various support funds for those accessing assessors in hardship, to clinical providers supporting waivers in hospital charges for individuals. Unfortunately, this means that there is no equity of access across the country. Some states and territories provide free access and some don't. Percentages of PLHIV taking art in various parts of the country also are quite different. In New South Wales, recent art dispensing data suggests that about 82% are on treatment, and for people from sexual health clinics and HIV clinics, it may be as high as about 88%. However, there's a minority of people with HIV, maybe 300 to 500 individuals in New South Wales, and who knows how many in the rest of Australia, who are negatively impacted by age, HIV, comorbid disease, poorer health and other socio-economic burdens. And as these people struggle to balance the financial burden of health-related costs with other living decisions, treatment initiation and adherence will be negatively impacted long-term. The health of these individuals will be compromised, and linked to this will be the added risk of the onward transmission of HIV. Achieving Australian 2015 treatment and prevention targets will require the removal of barriers to art for those who are under financial stress and vulnerable to either not starting or not being able to maintain treatment regimes long term. It is interesting to note that in the United Kingdom, Canada and various US states with large numbers of people with HIV, there is now public health funding providing free art and to HIV positive patients. The personal and public health arguments are real and established. And in Australia, we believe there is a real case for a reduction in antiretroviral co-payments, particularly for those who are under financial stress and may be considering either stopping treatments or not starting treatments. I'd just like to thank a few people. Joe Watson from NAPWA, Bill Whittaker, the Albion Street Pharmacy in Sydney, St Vincent's Hospital Pharmacy, and my POSAction colleagues, Queensland Positive People, Living Positive Victoria, and Positive Life South Australia. Thank you very much.